right, welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and we are honored to have Paula, our nurse practitioner, on with us today. Is a big honor because Paula doesn't like to be on these shows and do these things, but we've dragged her on and she's agreed to participate. We've done a two-part series which you must listen to, which was about OR nightmares and things that were just jaw-dropping, and you definitely want to check those out. And we thought, how appropriate if we then have another episode which then follows with what things should be like. So basically the two-part episode is what goes completely wrong and what it shouldn't look like. And today we're going to have an episode about the perioperative experience. What do I mean? What you should expect immediately before your surgery, the day of your surgery, and then immediately after your surgery. In other words, how should it go? What would be the perfect experience, and what should I expect? And then that way, as you're going through the process, you have cues that, wait, this doesn't sound right. This is not what they told me. And because unfortunately, as patients having your first surgery, for many of you, you may not know that something is off because you're like, how do I know that they were supposed to check my pregnancy test? How do I know that, and so on and so forth. So welcome again, Paula.
Thank you.
Very nice of you to join us. All right, so the success of your surgery begins before your surgery. So as you had said in your previous experiences, many times you would come to the day of surgery. You weren't on the clinic side. We're on the clinic side. By clinic, we're referring to the doctor, his staff, getting you ready for surgery. Many times, Paula would show up the day of surgery at the operating room, and the patients were clueless, had no instructions, knew nothing about their surgeries, frankly, were like deer in a headlight regarding what's about to happen. That right there is a catastrophe. You're automatically going to have a bad experience. So with me, and has been for 20 years, and now Paula is now part of that and is experienced it on the operating room side because she was the beneficiary of all the work we did on the clinic side, but now is involved in the clinic side. There is a pre-op in which we prepare you for surgery. It's a whole own visit. So a lot of doctors fly through the pre-op. It's something they do on the phone, or maybe they send you a couple of emails. We make an entire visit associated with the pre-op. And the pre-op is critical because two things happen. One, it allows us to give you every piece of information that you need in order to be successful. And two, it gives you yet another opportunity to ask every question you need to ask because, well, shit, I saw the doctor a year ago. Oh, I don't remember what he said. Oh, I've seen 5 other people since then, and I want to ask it. So we go out of our way to have a second appointment. So Paula, what are some of the things that are really important that we discuss with patients in the pre-op that needs to be discussed in order for them to do well and not have a complication? So let's go through some of our pre-op requirements.
So first and foremost, you always do a very thorough history and physical on the patient. So if they need any blood work, if they need any clearances from certain doctors that they see, if they need a mammogram, anything like that.
Great. So I'm going to highlight those as you go through it. So one thing we do, what I've done for 20 years is you come in, hey, Dr. Rahban, I'm interested in having a mommy makeover. Great. Tell me about your medications, blah, blah, blah. Tell me about your medical problems, blah, blah, blah. Oh, yes, I had history of supraventricular tachycardia, and I had a cardiologist, and the cardiologist did electrophysiology, and they zapped my aberrant heart pathway, and I'm good. Okay, great. So when and if you decide to do your mommy makeover, you need a cardiology clearance. Oh, but my cardiologist, I haven't seen him in a few years. He says I'm good. Great. When and if you have your mommy makeover, you need a cardiology clearance. So I am psycho about getting specialty clearances from people who have taken care of you for your problems. You can have successful surgery with almost any medical condition as long as that medical condition is well controlled. I have done surgery on patients who have had pulmonary emboli, which is like one of the worst complications you can have. And I've successfully done surgery because I was side by side with their hematologist and we had a plan and we executed it. So absolutely, if you have any medical conditions we're going to expect you to get a clearance. If you are older and you're having a surgery, we're going to ask you to get a regular clearance by your general doctor, which includes your EKG and your chest x-ray. You said mammogram. Every patient who is over 35, used to be 40, gets a mammogram within 6 months. What if I just had a mammogram? It was 9 months ago. You need another mammogram. I just had it. You need another mammogram. I have a story for you that I'll tell you. I was taking care of a doctor, worst patients in the world. I was taking care of a doctor. She had her mammogram 7 months prior to her breast surgery. So we have a protocol. Protocol means you stick to your protocol. NASA doesn't, like the day of a launch, be like, well, it's close enough. It's like, no, it's not what we said. 6 months prior, you need a mammogram. So she had it 7 months. We told her she needs another mammogram. She threw a cow, wrote emails, was nasty to the staff. This is a waste of resources and money and yada, yada, yada. And I was like, listen, I don't know what to tell you. I can't help you. She finally did it begrudgingly. And what do you know? They found a mass. Now, it turned out that the mass was benign, but they had to work it up. And she was so apologetic, as she should have been, because she's like, wow, I'm so sorry because, at 7 months it was clear. I go, that's exactly the point. It can change over time. So mammogram, labs, what kind of labs do we get?
I mean, depends how old the patient is and everything like that, but basic labs, even if you're a 25-year-old going in for just a straightforward like breast aug or like a rhinoplasty, just your basic lab work just to make sure everything's normal. Your blood clots at a normal rate, things like of that.
So we take a basic panel because we're assuming you're healthy. If you have other medical problems, then we will defer to that expert to get those additional labs. But as far as we're concerned, hi, nice to meet you, we're healthy, I need these basic labs, right? What else do we ask patients to do before surgery? Smoking, drinking, right? But what does that have to do with anything? Smoking is massive. Any smoking hookah, smoking pot, smoking cigarettes. Why? Because it affects your lungs. And then when we intubate you, you're at a higher risk of having pneumonia after surgery. Stop that shit. And smoking in particular has an impact on blood supply, and you can lose a nipple. What? Lose a belly button. What? You can lose the skin flap on a facelift. What? Yes, smoking does that. So we don't want you smoking, right? What else?
Important to always, if you want to talk about like Ozempic, Mounjaro, semaglutide.
So now is huge is semaglutides. So what's the issue with semaglutides? So I think the national requirement, but I think what's generally required is for you to be off of a semaglutide, like an Ozempic, Mounjaro kind of thing, for 2 weeks. We here in our practice require a month, and this is why. So what's the issue with the drug? The drug works in many ways, and one of the ways the drug works is by slowing down your stomach. And therefore you eat and you're not hungry because you haven't cleared the food out. And so it kind of just lingers and keeps you satiated. The problem with that is that when you have surgery and you're under anesthesia, if your stomach is full and you vomit while you're asleep, you will aspirate that goes into your lungs and you will die. And there are people who have died since the introduction of these drugs from ARDS or lung issues. And so we want you off. The reason we want you off at a month instead of 2 weeks is because there are still people at 2 weeks where their gut motility is still affected. We want to make sure that's off. The other thing we want you to do is we want you to be close to your weight. If you got a few more weeks, do not gain weight before your surgery. But I'm having a rhinoplasty. Then I don't care if you're 500 pounds. But if you're having a breast lift, if you're having a tummy tuck, if you're having a liposuction, if you're having a facelift, it matters for your weight. So we really want you to ratchet down your weight. What else?
Recreational drugs, marijuana, like you mentioned, cocaine is a big one. A lot of people don't find the need to disclose that. So I always ask them specifically about that because they don't realize how much it can change your heart and your EKG and surgery.
Right.
And it's so dangerous.
Cocaine in particular, right? All drugs before surgery are bad because it jacks up your medical system. But cocaine in particular, people know of young adults getting on a basketball court and dropping dead. And that's because they did a bunch of coke, and cocaine has the ability to alter your conduction pathways. And a result, you can end up getting what's called aberrant pathways and leads to tachycardia and things of that nature. And it doesn't take a lot of it. And so, especially if you've done it recently, you want to tell your doctor and the anesthesiologist, we're not going to turn you into the police. I don't care. Do whatever you want. But sure as hell, you should let us know so that when we put you to sleep, we don't end up having a complication. Also with supplements, one of the things that we try to avoid is bleeding, right? Like, I'm operating on you. I'm going to cut you open, and we're going to pray to God that you stop bleeding, right? Because your body has to clot. So there are drugs, many of them, that affect the clotting pathway. So aspirin, all the anti-inflammatories, and then this is the one that people don't expect, a boatload of supplements, such as
A lot of things in food too, like garlic,
fish
St. John's
oil,
wort, all those things.
fish oil, flax seeds, and chia seeds. Wait, those are so good for you. Yeah, they're great for you, but not great for surgery. And I have had patients who are on like mega fish oil levels, removing a mole or getting filler and bruising like hell. It really thins out your blood. So those are very, very important things. And what you want to make sure is that you get all the instructions. So instructions mean what? You had said in one of your kind of the nightmare stories we talked about, is a patient had a tummy tuck, and post-op instructions for surgeries are really important, because what you do after a facelift is not what you do after a tummy tuck, right?
Right.
So you were telling me that a patient was having a tummy tuck. You were seeing them in the morning of their surgery. You're like, all right, let's just go over everything again one more time. So you're going to do X, Y, and Z, which is like stay hunched over. And they're like, huh?
Yeah. Like, no one told me that. And I was like, what do you mean? What did you do in your pre-op? And she's like, I never had a pre-op. And it was like her first time meeting the doctor in person. She's only met him on Zoom. She didn't know she was going to have a drain after a tummy tuck, like basic things.
Right. And so often now, surgeries become casual. Oh, where'd you meet your doctor? Oh, I saw him on TikTok. Oh, and then, so did you meet him? No, I did a consult with him online. Okay, great. When are you going to meet him? The day of surgery? You're going to fly from across the world and meet the guy the morning of your surgery. So I do a lot of patients that are from abroad or out of state. We meet them on Zoom. Every single patient I've operated on in 20 years, I meet them the day before. I meet them in a formal consult. Hi, nice to meet you, Jane. Let's look at your nose in person. Oh, wow, you have a perforation. I didn't expect that. Oh my God, you've changed since your Zoom. Or wow, what do you mean I'm meeting you the morning of? How the hell am I meeting you the morning of? Well, don't you want to meet your doctor before the surgery? So I'm very adamant, and instructions are critical. So we have pages and pages. Wear the binder this way, wear the drain this way. This is how you would stand. Expect this, take the wrap off at this many days. So we really want to educate them. So that in going into it, they have read it, they prepared, we give them the paperwork, they can sit there and study it. It's very, very important. Okay, so that's the before the surgery. So tell me the process the day before. We call them, right? Do we call them the day before?
Yeah, so either myself or Sandra from the surgery center will call, and we review everything about what to do the day before the surgery and the morning of surgery. So we go over what time you have to stop eating and drinking, because that's super important, because you can't eat and drink for anywhere from 8 to 12 hours before your surgery, or your surgery will get canceled.
Right, so stop there for a moment. We're going to elaborate on that. So first of all, 8 to 12, there's a lot of discussion about that. 8 to 12 is fine. If you don't eat anything or drink anything after midnight, you're usually okay if your case is around 8. However, if you have had a semi-glutide and I stopped a month in advance like you asked me, still it's 12 hours of NPO. Why? Because your gut can still be slow. So that's that. And secondly, we have had, I don't know how many patients come in the morning like, oh, I just had a sip. A sip of what? A sip of coffee, a sip of this. Wait, what part of NPO do you not understand? That's eating. Like drinking is eating. So we mean NPO. What else?
Like the day before, we also go over what to wear to surgery. You have to come in loose clothes, something that zips in the front, nothing over your head, a lot loose pants, easy to put on shoes, something warm, because people are usually really cold after surgery. No makeup, no lotion on your body.
Don't bring 1,000 piercings.
Yeah, no piercings, exactly. No body jewelry. If you have a nose ring and you're getting a rhinoplasty and you can't get it out yourself, go to the tattoo shop and get it out a week before your surgery. Things of that sort.
Number one. So exactly. So we're going to elaborate a little bit on that. So don't come in here with your Rolex and your jewelry and your Cartier bracelet you can't take off. Sort these things out before you go to surgery. Don't be that patient. You know you're having surgery. Don't come with a boatload of makeup and perfume. I had a patient once that I operated on. She had so much perfume on that I actually had to step out of the OR. I don't think I was having some kind of like seizure or like some kind of reaction. So don't put on perfume, don't put on makeup. You're just going to get sick. If you have dentures or loose teeth and things of that nature, tell the anesthesiologist, take them out, do whatever you have. Don't come with your contacts in your eye. And then loose clothing. I had patients come, I'm sure you've had it because you're the one who changes them and dresses them. They come in like a tube top or something, like tight jeans. Are you out of your mind? You just had surgery. Why wouldn't you be in sweats and a zip up?
Yeah.
So that's very, very important. So then you get there. Let's talk about the day of. What should they expect? Because again, why we're telling you these things is, one, just so you know them, you're like, this looks familiar. You're going to have surgery one day and you're going to be like, this sounds like kind of familiar. And secondly, when it's not this way, then you know something's wrong. Because this is not special what I'm telling you. This is standard. So what should they expect the day of?
Yeah, the morning of surgery, they come in. There's going to be some extra consents that you have to sign for the surgery center part of things. After you sign all those things, review those papers with you. If you're a female, we'll bring you back. Get a urine sample to run a pregnancy test. Hopefully that is negative. Once that is negative, bring you into the room. We have you get changed into our gown. You take all your clothes off. You put all of our stuff on, and rearrange your hair in a certain way. If you're getting a facelift or things like that, these things all take time. So
I should be there 10 minutes before, right? What time should I get there?
Well, we usually have patients come about an hour or two before surgery because all of these things take time.
It's exactly like the airport people. If you are told to come 5 minutes before surgery, you should be alarmed. You need to come. It's time consuming. It's slow. It's methodical. It's decisive. So come, take your time, fill out the paperwork, go to the back, go pee before surgery, put your belongings aside, say goodbye to your loved ones. You don't want to be in a rush the morning of surgery, just like you don't want to be running down the tarmac praying to get on an airplane. So definitely take some time, right? So then you put them in the room, they're in a gown.
Yep, and then usually before you come in or the anesthesiologist comes in, I go over my own history and physical with them, reviewing everything again, any changes to their medical history, anything. I accidentally had a bagel this morning, things like that. I had coffee. I forgot I was not enough coffee. So I review all the things. I go over all the prescriptions with the patient, especially if they're not going to an aftercare. I review all the prescriptions with them so they know which ones to take, when to start, how to take them.
Right. So many times you get medications and you don't know anything about them. Well, if you don't know what your meds are, when to take them, and why you're taking them, how are you going to be successful post-op? Pain management is a really big problem with surgery, and that is I need to know when to take my pain meds, how much of it to take, how often to take, what if it doesn't work, those kinds of things. Nausea is a big part. What if I'm nauseous? What do I take? When do I take it? So these are things that your surgeon and his or her team should have told you well in advance in the pre-op that you should have had, and again reiterated by the nurse that morning, and review with your medication. So if no one is talking to you about your meds, no one's telling you when to take what, you got a problem.
Yeah, I think the morning of surgery, there's no new information the morning of surgery. It's just kind of reiterating things. And we always have everyone actually bring the physical prescriptions with them in the morning so I can physically show them.
Right.
This is your pain pill. This is what it looks like. Everything's labeled, but it's still good to see it.
And how many times in the past, because what you just said was exactly right. All I'm doing the day of is going over what you've been told, just reminding you about it. But how many times in the past have you shown up the morning of and it's like you're telling things to the patient for the first time?
Yes. I mean,
lot. Almost all the time, right? Because patients are not either prepped and or not paying attention.
Yeah, I've had patients come to surgery and I'll be like, okay, you have your antibiotics and your pain pills, you have everything. Did you pick them up? And they'll be like, oh no, the office said they're going to call them in for me. They come into surgery and they don't have their prescriptions ready. Things of that sort. And I'm just like, what?
Yeah, so it's very, very important, and we're very thorough, but not everywhere is going to be that thorough. So it's on you if you haven't gotten these things and no one's explained them to you, that they literally explain these things to you. The anesthesiologist will come in, or they ought to. You should meet the anesthesiologist. If you are brought back and you never meet and never see the eyeballs of your anesthesiologist and the eyeballs of your surgeon, you should be stressed. Every single case, the anesthesiologist walks in, introduces themselves, tells you about what's going to happen from an anesthetic standpoint, and I come in and I see you and mark you. There have been instances where patients never see the surgeon in the morning and they have no idea if they were there or operated on them. Did you hear what I just said? You literally come to the operating room, the nurse takes you to the back, and you fall asleep, and then you wake up and you never know if the guy was there or not to do your surgery. So eyeballs, you need to see eyeballs.
I would also recommend patients before they come in. There's been so many times when patients come in and they're like, oh, I had a question last night, but I can't remember it, and this and that. So I'd always recommend, if after your pre-op you went home, you had a question, I'd always recommend physically writing it down, either it's on your phone, on your notepad, and then bringing that with you the morning of surgery to review that so you don't forget it, so the question gets answered before you go home.
Yeah, so you have three options. Let me rephrase this. At least in my practice, you have three opportunities, 1, 2, 3, in which to see me and have discussions with me. One is at your consult, psycho long, thorough. 2 is your pre-op, psycho long, thorough. 3 is the morning of, should be sweet and quick. But you still have it. So you should be able to be like, hey, Dr. Rahban, I'm so sorry. Can I ask you one more question? Sure, honey, what's up? Oh, I forgot to ask you, da-da-da-da-da. Now's not the time to be discussing surgical plan and all that other stuff, because if that's the case, then you and your surgeon are in big trouble. If you are going the morning of surgery and you need to sit down and have a full-on discussion with your surgeon, cancel the case. Did you hear what I said? If you get to the morning of your surgery and you're like overwhelmed with anxiety because you don't really understand what's about to happen, cancel the case. It's elective. Do not move on with the surgery. I don't care what financial damage occurs. I don't care what kind of deposit you lose. The morning of your surgery should be the morning of your wedding, filled with a little bit of butterflies, mostly excited and in anticipation of positive, and you can't wait for it all to be finished and for you to be on the other side. It should not be nerves, anxiety, nausea, scared, not knowing what's going on, and being misinformed. That is not the way to have the morning of your surgery that way. Okay, so we take you in, and then the nurse will start an IV. So patients are always wanting to know, oh, is it painful? What do I know? And the worst part, at least as far as pain, is an IV starting, which in and of itself is not painful. But they'll start your IV, and then after that, you don't remember anything. Because what happens is we take you to the operating room, and we talked about this with Dr. Houston in the Anesthesia podcast we've done. We bring you into the OR, you're talking, hey, wow, it's cold in here. Oh, that's cool. Oh, wow, this looks just like a TV show. And we're gonna say to you, count back for us from blah, blah, blah. And next thing you know, you're putting on your underwear and your pants. What time is it? Oh, it's noon. 12 o'clock? Are we done? Yep, we're done. Wait, what happened? You're like, what do you mean what happened? We did what we said we're going to do. Because that's all you remember. Modern anesthesia is phenomenal in that it has something called retrograde amnesia. You actually forget walking in the room. You forget the last bit of conversation you had with your anesthesiologist because it erases about 15 minutes of it. That's what's so amazing. So, all right. Surgery's done, they wheel you into recovery. So then we hand you off to the nurse. So what should they expect from there on once they're in recovery?
Most people, they wake up, you're going to be groggy for the beginning. You'll probably be speaking and talking to me. You probably won't remember it the day after. Sometimes people wake up, just depending on the nature of the surgery, a little cold, a little shivery, which is totally normal. That will also go away. Everyone always gets a little frightened by that, so I always warn people of that. Put them on a bunch of warm blankets, just give you some time to wake up. We'll hook you up to all the monitors. I'll be checking your vitals every 5 to 10 minutes, just depending on what the orders are and if you have any pain, if you have any nausea or anything. We try to control all of that before you get discharged with medications. I'll be taking care of your drains and things of that sort in recovery, reviewing with you how to take care of your drains again, and just making sure you're comfortable before you go home.
Yeah. So the key for your recovery is that when you enter your car with your loved ones and or the recovery center, you are not in massive pain. You're uncomfortable. That's normal. You're not nauseous and hurling, but your nausea is reasonably well controlled. Your drains aren't filling up with blood constantly, but they're dry and been drained out, right? Your dressings are clean and dry and you're not bleeding through them. You need to be stable when you leave the operating room and when you leave the recovery and you're handed off to the next person. The baton is passed off. And what needs to happen is that your loved one needs to receive a verbal sign out by the nurse. Hey, okay, Julie's did great. She did fantastic. Here you are. We're going to put her in your car. Here are her clothes. There needs to be some conversation. I just gave her a pain med. She should probably in a few hours go home and start taking some cold side chips and maybe some banana. You might find if she's uncomfortable, I'd give her another half. There needs to be this dialogue. Again, if you just get thrown into a car, slam the door, and off you go, that's a problem. At that point, it's too late because you already did the surgery. But if a friend of yours describes that experience, then you should be very careful when you're at that facility because that's not a normal discharge experience.
Yeah, I always with the family, like if they're going to an aftercare, then it's a different story. But if they're going home with like a family member or anything, I always go over all the discharge with the family member as well. I go over all the medications, take this medication at this time so they know because a lot of the times they're like, what are all these meds? They're freaking out. So I go over everything with them to make sure that they know how to take care of the patient at home and they're comfortable with it. All their questions are answered. I never just put someone in a car and I'm like, okay, good luck. Like, you're not my problem anymore.
Thanks for coming. Bye-bye.
Yeah, so just making sure that whoever's taking care of them after is also educated, making sure that there's someone to stay with them after and they're not just dropping them off at home by themselves.
And by the way, this is a huge thing, huge. But you cannot be discharged to Uber. Do you understand, people? I'm going to reiterate this. You need, okay, no problem. My 14-year-old, no. You need a goddamn adult to pick you up that knows you. If you have a complication, if you are that 1 in 500,000 that has a reaction to lidocaine, oh my God, I hemorrhage, you need someone to give a shit. So patients, oh my God, I can't tell you how many patients are like, can I just go home with an Uber or a taxi? I live real close to Airbnb. No, we're not going to hand you off to a stranger, no less a robotic car that's empty, right? Yeah. Like, you need an adult. Don't come to LA to have a surgery or go anywhere in this country without an adult with you. Do not go to, oh, the guy said I don't need anybody and I'm okay by myself. You're not okay by yourself because you are still a patient and there is still always something that can go wrong. So definitely make sure that at least for the days, immediate days following a surgery, you have an adult with you, someone that is responsible, someone that can call 911, someone that can call the doctor and ask questions, anything, just take care of you. I think that's really, really important because I'm sure, we won't, but I'm sure you've had doctors discharge patients to a taxi or an Uber.
I won't. Like in pre-op, the morning of surgery, I'll always ask, who's your ride after? And I've had patients say, oh, I'm just going to Uber. I can't legally sign out a patient to an Uber. Like, I just can't do that. I can't do it. So I've told surgeons I won't do it.
Right, but that's the crazy part that I'm talking about is you have to be like, no, when I sign out, it's me saying I discharged the patient. So it falls on me. I'm not going to do that. The crazy part is had you not done that, they would have discharged them. I mean, it wasn't like, because you know that who's picking you up gets decided in pre-op. Mm-hmm. That happens in the office. You should just be there to just be like, okay, who is it? You shouldn't be the one arguing in the morning of, wait, I'm not sending you home with this. You got to find someone before we. So that goes to show you that had you not been the one who called them out on it, patient would have been put into an Uber and sent home. It happens all the time.
Yeah, and it's like then they go to their hotel. There's no one there. God forbid, what if something happens to you? What if you're dizzy after anesthesia? You get up, you fall, you hit your head, and you're alone.
It happens all the time. So many instances. So-and-so's mother of 8 found in hospital. Was taken. Like, you cannot have anesthesia. Even if it's just a normal reaction to anesthesia, like you just got lightheaded. Like, you literally can get up and go to the bathroom and get lightheaded from orthostatic, from still having some narcotic in your system. Okay. My wife had severe spine surgery, was on a ton of pain meds. She went to go to the bathroom and she passed out. Mm-hmm. That's not anyone's, that's what happens when you have surgery. Mm-hmm. So, I think The purpose of this episode was for you guys to know what's normal, right? Then you can compare your crazy boyfriend to that amazing boyfriend you once had. You have to have a point of reference to know what is or isn't right. And while it isn't the holy grail, none of the things we just mentioned to you are at all by any means outrageous or unusual or weird. They're all basic things that they would be required. So hopefully you found that helpful. This is what I call the immediate perioperative, the immediate time around an operation timeline and what to expect. And if you decide to surgery, we obviously wish you a successful and a very healthy outcome. All right, Paula, you're off the hook.
Yay.
You get done, you can go eat your lunch, you can go and frolic and enjoy your day. As always, that's a wrap with Plastic Surgery Uncensored. We have two parting requests. Number one, go and write a review, stop whatever you're doing, unplug your earbuds, don't listen to the next episode of any other true crime. Go write a review right away, because I know you love our show. And secondly, share this immediately with people you love. Everyone's like, after the fact, oh my God, I didn't know my cousin had a surgery. God, I wish she had told me. I can't believe she went to blah, blah, blah. Well, it's after the fact, it's too late. So if you share this show preemptively to friends and family, you will have done them a service. All right, guys, that's a wrap. That's another episode of Plastic Surgery Uncensored. As always, your host, Dr. Rady Rahban. I will see you all next week.